So I'm just going to go to the next slide of mine. So I'm going to take you through something which is popular across all aspects of healthcare system, which is risk assessment. So currently, if you look at any accreditation or certifying body, they are always asked for, have you done the risk assessment? Are you doing the risk assessment? And all of us who've been in the laboratories know that risk assessment in diagnostic lab is very important, not just for accreditation. Now we also understand how we prioritize things, right? So I'm going to take you through infection control risk assessment. It's known for years. We've been doing it. Only thing is we understand today by name, and we've given this name to this saying that, okay, this is what we call as risk assessment, but we have been doing this forever. When I tell you some examples, you'll say, oh, this is all that you're talking again. So what's new in this? That's what you're going to say at the end of the session. But I would want you to look at it a little bit more in detail so that we use the strategic point of this learning into actual practice. When you're trying to implement in your own facilities, or when you finish your post-graduation and start working in another institution, or you handle laboratories as a consultant, you should never be very unfamiliar with this term. So let me take you to this. Whenever we see a hospital, let's take a 350-bedded healthcare facility. So what they had is, whenever you look for an accreditation, when they go in for an accreditation, or when they get ready for a hospital, for preparing themselves, for presenting themselves to be fully equipped, etc., they look at whether the hospital has the monthly healthcare associated infection rates or surveillance reports. Do they have the hand hygiene data? And they also try to present it as more than 80%. They look at the antimicrobial policy, whether in papers or in practice. And they also look at whether there has been any antimicrobial stewardship activity specific. And then they look at whether they have the infection control nurses or not. Okay, so this is all that they have. But what they don't have is what is specific to them. What is that they need to have? Okay, so what is missing? Can anybody suggest what's missing from this hospital? Can you just put up in the chat box what is missing? Hello, graduates. Okay. Is there anything that's missing?
They are typing in, ma'am, in the
I can
box.
see. Excellent. Ikra, RCA Kappa. Yes. Okay. Okay. Right. You're right. So what is missing is that they don't look at what are the gaps that we have. What is the area that I need to focus? Okay. So what is missing is annual infection control risk assessment. It could be, something like a framework that they look for, or a response that you see, depending on what you're following, whether it is a CDC or a WHO. Okay, the CDC kind of looks at whatever is more US based, but it kind of looks at the similar things, specifically looking at all areas, and sounds specific to the acute care facilities. All right. And then there is no risk stratification and risk prioritization, which means there is no focus on what are the areas that I need to look at, which are the areas that I should focus on. Because every healthcare facility is unique and every healthcare facility is different. And each one has a different challenge than the other. Okay. So what is that we're going to see in the next 40 minutes or 45 minutes? Why do we do an infection control risk assessment? What do we assess? How to conduct an ICRA? How to implement these in our healthcare facilities? And how do we evaluate whether what we have implemented is working or not? Okay, so these are the things that we look for. Now, what is risk? It is a possibility of something bad happening. I'm sitting here, the roof can fall down. Okay, so you are in your workplaces, your systems can just go off. Okay, but what is that is there with this risk? It involves some kind of an uncertainty. It can happen, it may not happen. My Wi-Fi can stop suddenly, between the session when we are having a good conversation, trying to engage with each other in trying to learn in an online platform. I sitting in Tamil Nadu and you all sitting in Telangana and Andhra Pradesh and listening to each other. Okay. And suddenly my Wi-Fi goes off. So that's a risk, isn't it? So what is that? If I know this is happening very often, then I would look at, some kind of a backup I will have. So that's what is important. So looking at what may be my risk and getting ready for it is what is the prioritization that I need to know. Okay. And healthcare is very complex. It has multiple inputs and outputs. There are too many people, activity, facilities, and resources and personnel and systems and equipment that come in the way, okay, in a healthcare system. It's not just that one in and one out. There is multiple ins and multiple outs. So therefore, you should look at it more complex. And IPC is a supreme star of this complex system. So infection prevention control also has these kind of complexities, and we need to look at what are the risks that we would have. And that's the likelihood that you look for of any hazard which could lead to a harm. That's the risk. Okay. So this is just to show you the difference between the hazard and a risk. Hazard is something, can harm you. How often, how likely that it can harm you for sure is your risk. So the risk is dependent on multiple things because infection itself is dependent on various. So infection control activities that you do in any healthcare facility depends on multiple things because each healthcare facility is unique. So I always give this example. So if you've heard me already, I would have definitely given this example. I work in a medical college hospital, which is part of a corporate hospital. The whole of these two hospitals are within a single campus. So there is a 1,200, 300 bedded or more corporate hospital, and there is a 750 bedded teaching medical college hospital in the same campus. The type of population that attends the medical college is different from the type of population of patients that attend the corporate hospital. The specialities that the corporate hospital handles is different from that of the medical college because corporate hospital has, transplant units. They do have, they have their oncology blocks much more well clearly defined compared because there's a new medical college with 5-6 years of experience. So there is no, oncology block as yet. We do have patients, but not as a specialty block. So the corporate hospital does a lot of high-end activities like robotic surgeries, name it, everything is there, CAR-T procedures for therapy, a lot of things. So the patient populations are different. And here it's more of a general hospital kind. So you have patients coming for the first time visit, and also you have the tertiary care kind of a setup that comes to this teaching medical college. So you have a population which is different. The type of manpower is different. The number of patients to the healthcare workers ratio is different. The type of patient, the activities that are done here to that of that hospital is different. So the risk for specific infections are very unique because you can have more immunocompromised patients in the corporate system having more different types of infections there. Treatment and care practices are very different. Instruments and medical devices, cleaning, disinfection, handlings, very, very unique and different. The equipment is different. The chemical or methodology chosen to do is different. Personnel's doing it is different. The systems and environments are different. The environment of care itself is different. And sometimes there is a difference between, a planned procedure to that of an emergency procedures. We see the difference whenever there's an elective surgery and an emergency surgery. The risk of a surgical site infection is definitely more in an emergency. You all understand the chain of infection, and of course, it's important to break the chain, and all of the others add to this risk of infections, and which is unique for every population. So you cannot have the same thing in each. So it depends, each area is different, and therefore the risk associated with these infections also is different. So what is this ICRA going to do? This is a multidisciplinary, very, very organizational. It's a documented process, kind of looking at how to reduce risk of infection in a healthcare facility. So what is done? You do a risk assessment and then you do a plan, and this whole thing becomes the foundation of a program. Now, every healthcare facility should have an infection prevention control program, which has to be defined for the year. Okay. If you are not defining it for the year, at least you review the existing and see whether it is acceptable and it is for the system, right? So this is based out of the risk assessment that do, which means every healthcare facility's infection prevention control program is dependent on the assessment that you do, then what you plan out for. So it's that risk assessment becomes the starting point. That's where you start. Okay, so you look at various important issues of the organization. So you identify what all can go wrong, what all can go wrong in our own organization, and then you kind of look at what all can go wrong in any system, then you look at what can go wrong in my system. So this would help us to define our program. So what is my focus? Where should I focus? And how do I get this addressed, right? So why conduct this? This is to improve the patient and staff safety, to improve the efficacy of protocols and procedures so that you know that your focus areas are specific and you are working towards it. You identify training needs because you see those are the risk areas, and you know to address that you need to have trained, competent personnel doing these things. And you also kind of help to develop hypothesis, because when you have an outbreak, then you start to react to it. Instead, you kind of proactively try to see something and then you prevent it. So you kind of develop hypothesis. Once it has happened, then you want to see that it does not happen again. So you always look at how do I prevent it? So you kind of develop hypothesis as well. You justify the need for various resources. Now, if you see these are my areas of concern, you know how much of funding allocation should be done for this. When you are preparing your IPC budget, also you know where you should focus your funding on, what you should invest on, what you should be, focusing on, right? And ultimately to avoid any adverse event within the system so that you don't have most often an outbreak or serious complication of infection as a sentinel event. So what will you assess in a risk assessment? You will have to see who's at risk, whether it is a patient, is it a visitor, or a healthcare professional, or the community. So when you're doing any risk assessment, you see which category of person is at risk. And you look at what infectious agent or organism is involved, whether it is a Staphylococcus aureus, whether you're looking at a SARS-CoV-2 virus, or you're looking at Vibrio cholera or chickenpox, which are these organisms? And what you're looking at, what is the mode of this transmission? Because in your cycle of infection, chain of infection, you always look at, the agent and the mode of transmission and what leads to the mode of transmission, whether it is contact, airborne, droplet, etc. And how likely this happens in our system. How often can it happen in the system? You have a system with very good IPC practices in place where people are wearing appropriate PPEs, they know how to wash hands. There's a less likely chance of transmission of these infections. So you are going to apply some basic knowledge. You also look at what is happening in your system to identify this. And you see what are the consequences. Is somebody going to be hurt by that, by these risks? Is somebody going to die? Or is it just going to do nothing to these people? So what is that consequence of this particular risk? So the next thing what you do is, how can I prevent it? And prevention is something that you do before it comes into the system. Controlling is something that you do when it's already established in the system and you want to bring it down. So you look at what are the things that I would do to prevent it and also to control. And what am I going to do in my existing situation? So these are the things that I would assess in the whole thing, right? So if you look at the steps of performing the infection prevention control risk assessment, first and the foremost thing is that I need to have a team. Okay, I need to have, it's not just one person, it's going to be a team of people who brainstorm, bring up ideas, and then discuss. It could be your IPC team alone, or you can have concerned personnel from various other departments as well to form and then have a team of risk assessment. There are organizations who have experts who are, who do the risk management itself. They do the organizational risk assessment. They also do the specific, area specific risk assessment also. So there are trained risk analysts who do or assessment people that done, and that's a job as well. So then you establish timeline. How long would I want to assess this, and how much of data would I capture, and how long do I do this, and the process for doing it and establishing them. So you have a Gantt chart or a timeline created to see, by this time I would have assessed this, and I just start to look at it and review this and go ahead. Collect all the relevant data from our own organization, then some from the literature, because if you don't have, or you are new to the whole system, it's a newer facility, you have no data of IPC at all, then you take from the literature or from the IPC communities or specialist groups, okay, or consensus teams that they would give some input. So these are the various ways that you would get the data. Develop an assessment. So you have various methods, and you can create a template to specific to IPC, and you do the risk assessment. Then educate the staff in performing. This is the most important thing, because if I do an assessment and I score something, and somebody else does the assessment and scores something else, okay, if it's going to be different, then there is not going to be any sense, because if I would score something and you score something else, okay, it will always almost look like this month to next month there has been an increase or a decrease depending on, but there may not have been any change. It's just that there was error in the person who performed the assessment. So for standardization, first of all, you need to educate every staff. And when you do a staff education, you need to focus on, each aspect of the area to be trained. Perform the risk assessment and you prioritize which one you're going to focus. Then to address that risk, you develop infection prevention goals, objectives, as well as activities. So these are the various steps in the risk assessment process. So what are the tools that are there to look at? One, you can use a qualitative tool, because by visually I see certain things when I said, okay, I think this is a bigger problem in my system. So that's a very qualitative one. Then you have also a quantitative. The most often used tool, okay, whether it may be in diagnostic microbiology or laboratories in general, or in anywhere in the healthcare system when you want to do a risk assessment, is matrix scoring. The others are trying to look at strength, weakness, opportunities, and threat, which is a very qualitative one. You can also do a HVA or hazard vulnerability analysis, or looking at hazard analysis and critical control points, which is those crucial points which can alter a system, become bad or worse, that one thing that we didn't do properly. And then failure mode and effects analysis, most often done in the laboratory, but you could also do it in the hospital settings or a healthcare settings. Okay, so you'll kind of let's look at the qualitative one. This is a SWOT analysis, very simple, straightforward. Just an example here. Poor hand hygiene compliance. The compliance is 42. The desired is 80. You find what the gap is. Inadequate training and not giving feedback to the concerned person. The action plan is conduct training, tell people. Is it a priority? Yes, because of the focus that we understand that the hand hygiene compliance is important. So we prioritize it as a very important thing. So this is a qualitative one. Let me take you through this one. So what else? Okay, let me ask you. So what are the various other areas in IPC you think would be identified as a risk? Can you just put up in the chat box? What are the other areas that you think is a risk? IPC risk: contamination, high HAI rates, okay, biomedical waste management, needle stick injury, excellent. Construction near OT, excellent. Needle stick injury, ICU, okay. Isolation protocols, very good. needle stick injury. Okay. All right. Good. Okay. Biomedical waste segregation. Perfect. Okay. Now, let me ask you this question. Now you answer this. I wanted to put this as a poll, but unfortunately I couldn't. Which of this is a major risk? Low hand hygiene complaints, construction near the ICU, high antibiotic use, poor waste management. According to you, only one answer. You cannot give all. Just tell me, okay, put up in the chat box again. What would you consider as the priority? Okay, one. C. Okay. Okay, poor waste management, hand hygiene, low hand hygiene complaints, poor waste management, high antibiotic use. Okay, low hand hygiene. Okay, hand hygiene complaints. Okay. So when I look at it, okay, I've just seen probably 20 people of you responding to this. But I see your response. I understand most of you have poor hand hygiene complaints as the priority, and the second is being the poor, segregation and disposal of biomedical waste, and of course the ICUs. Okay, then also the high antibiotic use, which has been the third or the lowest one. But remember, this is specific to each area, each hospital. For example, the same hospital A and B in my condition, let me call my hospital A and my corporate hospital as B. My hospital would have a different concern than that of the corporate hospital, though we are in the same system, same management, same structure in a lot of things. Okay, the practices are similar sometimes. The usage of material is very similar in most of these areas. So, but still, we will have a risk which is different from that what the other hospital has. Okay. This is also because of our practices within the system, our healthcare professionals' attitude, the way it's been done. My poor hand hygiene complaints may be my high priority risk. For them, the other hospital, maybe they have a good hand hygiene complaints, but their antibiotic use is not under control. So each facility has a different area of focus. How do I know what is my priority area? So let's come to the second part of the system where kind of look at how do I know what is my area of focus, for which I need to quantify it and give them a number. When I qualitatively say, I list all of them and say, these are my problems. And obviously what strikes me big, I will say, okay, this is my problem. But when I quantify and give numbers, I may be able to put the biggest problem on top and come down to the smallest at the bottom. So I will know what is my big priority problem. Okay. So for which, of course, we have to look at in our entire IPC. That's why we need to have a team where we brainstorm to see all that can be wrong at our system, all that can go wrong at our system, and then we prioritize. For which we use this particular matrix. This is a 2x2 matrix. Of course, we use 2x2, not just 2x2. We use 3 parameter matrix. But this is the simplest. You could just use this. Any matrix can be used. It's not that you have to follow only this particular way. Okay. The simplest is likelihood of an occurrence and severity. Hazard severity and likelihood of occurrence. Severity is something to say whether is it nothing or no effect to a range of catastrophic or death? Is it going to kill the person or do nothing to the person? That's a range you will have. There is a midpoint where there is an injury, minor injury, major injury. So you have 5 points. There are systems where they can even give 10 points also. So you can choose whether. So if you want to be more critically scoring them, but in my experience, I feel this 5 point is easy because it's easier to teach people also, and I can score also. If I say 1 to 10, score between 1 to 10, 6 and 7 is very closely similar. So people usually put 6 and 7 similar, 4 and 3 similar. So there is a lot of confusion with that. But this one is very easy. Like you have nothing, then there is death. There is a midpoint of an injury, then minor injury, major injury. So easy. So that's what I choose, but you can choose whichever you like. Then there is something which is the likelihood of occurrence. The likelihood of occurrence again is very, very unlikely. Okay, this roof falling on my head is very, very unlikely. But can it happen? Yes. Very, very unlikely, but can happen. And very likely is suddenly my charge going off when I'm talking is likely in my system as of today. Okay, so then there is a possibility of it happening, and unlikely to likely is that. So there you have 5 point again. Very simple, very easy. So these things would give. So you can if you look at the matrix here and you put it up like this as a table, you already give the color shades and it tells you whether it is a low priority one, medium priority one, or a high priority. But however, you will be taking these scores. We have put this as A, B, C, D, E, but all of them can be 1, 2, 3, 4, 5 and 1, 2, 3, 4, 5. And you can put this matrix. So another word of caution, okay, not a caution, just for and something that I would like to share. So the JCI standard always looks at adding the matrix data. That is, likelihood of occurrence to hazard severity is usually added. If you look at the diagnostic lab matrix, we always multiply it. Okay, if you look at your RPN score, it is always a multiplied score that you have. But here it's usually added, but you could choose either. There are articles to support both multiplying them as well as adding them. But what you choose to do it consistently the same, because your score should not change. Whether you add or multiply them, it's okay, right? This is from the NCDC that, just to give you an example, this is pretty much very qualitatively described. Okay, just to tell you how it kind of looks at. The same severity is given as an impact and likelihood as frequency of occurrence. Frequency of occurrence and impact is a severity. It kind of says, and tells how severe or how bad this is, and there is an action plan. In risk assessment or risk management, whenever you prepare, you always prepare the likelihood of occurrence, the severity, and also you will add the score and you will give an action plan or mitigation plan. If this happens, this is what my plan is. You do not look for a plan after it has done, after it is being done. So your risk, when it's identified, you also have a risk mitigation plan in place. So there is an action plan. So let's take some of the examples. I'm going to look only the IPC specific. There are flood and fire also. So I'm going to take only the IPC system not in place. It's a one-time occurrence only. The impact is very severe. So what is the action plan? Have a good system in place, organize meeting, conduct every month, etc. Okay, let's look at inadequate number of human resources for IPC. If this is a very frequent issue of people moving away, transferring, etc., it's definitely going to have a severe impact. So you have people, you have a system in place where you have a proper HR planning, recruitment, have people who are able to multitask, etc. So this is just an action plan. These are examples. Okay, you can choose however you would want to describe the same. Let me take the last one again before we move on. Inadequate training for IPC. Okay, so this inadequate training for IPC, this is more often seen. Okay, so again, this has a very severe impact. So what is done is training training the trainers first, and then getting them to train the people in all of the healthcare facility completely. Mandatory training of IPC during induction and periodic training, and promotions and incentives are based on how good their IPC compliance is. So these are some of the examples that's given in the ICDC document of 2020. I think it's a beautiful document. You should download and read about this as well, right? So this is just an example. This is pretty much, again, a very qualitative one where it is not specifically looking at values and numbers. But this is from the JCI white paper document, which kind of looks at. And here you will see, apart from the likelihood of occurrence, which is probability, then there is a severity or impact, then there is something called as current system or preparedness. So even in the laboratories, when you look for in the severity, likelihood of occurrence, you also have a third parameter, which is detectability. Okay, I'm sure you must have seen this. Okay, severity, SOD, severity, occurrence, and detectability. We do this in laboratory risk assessment also. Here similar, you have a probability or frequency of its occurrence. Then you have a severity or impact, which could be either health, financial or legal or regulatory. Can anybody tell me what is the regulatory impact an IPC will have? Can somebody put up in the chat box, please? What comes to your mind when I say regulatory requirement for IPC? Excellent. Excellent, Dr. Shalini. Biomedical waste rules. Excellent. So non-adhering to biomedical waste rules can have a very serious regulatory requirement. Okay, so it is a biomedical waste is a law, and you have to adhere to that. And breaching them, you can have a lot of fines that's been imposed on the organization as well. So that's definitely going to affect the financial as well, right? So current preparedness or the current system is, what are the gaps that exist in the current system, or how prepared is the system? When you look at the preparedness here, it are always looking at materials in preparedness, systems being in place, SOPs, systems in place, and having materials and having trained personnel to do so. All of these are the preparedness currently available. So what are the deviations? So it's always good to, here it is going to add, like I told you earlier, it's going to be adding them. And if you see this, this white paper of the JCI gives only 4 scoring. Again, it's very simple or easy, major, minor, moderate, minimal, like that, very simple, 1, 2, 3, 4. Poor, fair, good, good, and solid. Okay, so this is some details that it gives. Okay, so you put the colors, depending on the colors. If it's more than 10, you say it's high priority, and it's 5 to 10, you put it as medium priority, and low priority, less than 4. So you score them and you consistently keep that so that you are able to do it for your own system. This is not for a standardized comparison against another hospital or a system. It is for your own organization to see whether you are improving or otherwise. Now, how are you going to see the probability of an event occurring? Whether you know the risk already, whether there is a data available to you, is there a research data that is there? And you also look at the severity to see whether is it going to be life-threatening, what impact it can have, will there be a financial loss, there may be a litigation, surgical site infection, litigation, there is a financial loss, etc. Or training, policies, backup systems, that's the current system and preparedness. So this is the example that we have, right? Now, this grid is a visual tool, kind of helps us to say what is our priority, because once you start to score, you can tell which number is bigger than the other, and therefore you will know how to do it better. Now, how often should you do this? This is my own personal thing, is that to do it at least once a year only, because you keep changing your score. It's so confusing to the system. Your risk assessment matrix also keeps changing. But initially, when you start, you can do a 3 months data and take a data and start to do. And then once you're standardized, you go for an annual report. Every year, you look at previous years, and then, so then when you prioritize, then you can convert that into your IPC program plan also. So it will become more easy for you to do it once you do it annually. This is my thinking. I'm going to take you through some examples and see how it is done in a real life scenario or real system in each of the risks that may be identified. I'm just going to take you through some of them only, but you can help me with others, right? Hand hygiene, poor hand hygiene practices is a risk. But if you look at preventing infection, control or mitigation will always look at having a good hand hygiene practice in place. So it is most often a control measure. So washing hands appropriately and all the moments of hand washing indicated. Okay, those are just not risks that you see, but also control measures. PPE is something that has helped us understand risk assessment its best. Okay, so all material that you use to protect yourselves are our PPEs. But you do a risk assessment depending on the potential exposure risks. Where am I going to do? What am I going to do? In which locality am I going to do the same? And what procedure, what specialty am I going to do? So we do what is called as on-site risk assessment. So this is called as point of care risk assessment. So before handling a patient that's at the point of care, you look at what is the activity I'm going to do, whether I'm going to conduct a delivery or I'm going to examine a patient or just shift a patient from one area to another. Okay, so what is the condition of the patient? The patient is a suspected a patient with, some sepsis, or patients coming or being, transferred to another facility for higher care, where known drug resistance, etc., or tuberculosis patient, or patients with HIV. On which environment are we doing? Are we doing it as an emergency in the ER? Are we doing it in the theater, with all the facilities in place where your environments are more controlled? So that is the kind of risk. You always look at, what is my hand going to touch? Okay, so accordingly you do either hand hygiene or wear gloves. And depending on the type of activity, the type of protection and the risk, you also use different types of gloves. You either use a clean gloves, you use a sterile gloves, use a heavy duty gloves, depending on that. Will my skin or clothes get soiled or contaminated with secretion? So you wear an apron or a gown. Will my mouth or or the mucous membrane of mouth and nose be exposed to aerosols or splash? So I wear either a mask, surgical mask, or an N95 respirator, depending. So this is something that I would do on spot. I think this many of us still have as pictures with each one of us. This is something that was developed by the Ministry of Health, Family Welfare during the COVID time. And it gave us a clear, direction for a lot of people who are new to IPC on what you should do, what is the kind of risk each area will have. So when you're doing these activities in this area, what are the protectives that you should be wearing? So this is something that you can do even in your own facilities, when you can put them as charts near the labor room where you tell people what they should be wearing, when doing these procedures, and helping or guiding patients into what they should be doing when they enter isolation room, when they are in the CSST, when they are in the linen laundry area or in the mortuary. In all of these areas, you tell them what they should be doing and who should be wearing what, etc. So if they are sanitary workers, what are they doing? When visitors attending the OPD, what they should do? Those accompanying patients in the IP ward, what they should be doing. So for the healthcare professionals, for those who are at the registration counters or desks, so when they are during the outbreak, of course, it was very serious, and you know that everybody could be a potential infection carrier. So you have a common protocol for certain areas, and then specific to certain persons, specific to certain activities. This would guide. Okay, so it's very simple and easy to understand. Okay. And something that helped us understand the risk assessment even better was this needle stick injury, because you always look at identify the hazard. What can it happen? It can prick the people. You look at who's going to be harmed and how. Of course, a healthcare worker. Okay. Evaluate the risk and decide. So you evaluate whether the person can get HIV, HBV, HCV, or other bloodborne infection, and decide the precaution they should take. Whether they need to be vaccinated prior, they have potential, they have enough antibody titers to protect themselves. And you also look at, other precautions that they need to don before handling. You record the findings, and then you also implement corrective or preventive actions for these. Monitor the performance to see whether it has worked or not. This is a very simple for a needle stick injury risk assessment. Let me take you to another example. Okay, so we looked at the biomedical waste segregation. So here, what is the activity? We need to do a proper segregation. Currently, what is the status? That's not happening. So what is the hazard? There is an infection risk. How is it going to happen? This is because of transmission of infection. So how often is this poor biomedical waste segregation happening in the facility? Out of 1 to 5, let's put it as, this is an arbitrary number only for understanding and learning. The likelihood is 4. So what is the complication in a patient zone where you have a lot of blood body fluids, and severity of an infection risk is 4? Nobody's going to die of it, but definitely they're going to be infected with all kind of infections. But is there a preparedness? Yes, we have a tie-up with the third party, takes the waste, we have posters, we do the training, but all of these, but still not working. So what is that you need to do as a control measure? So we hear the score is 10. Okay, the control measure. So this is what you would have for each a risk that has been identified. So you may put the activity and hazard and status and effects may put, or you can just identify the risk alone. Then you will put the likelihood, severity, and preparedness. You either add, like I have given, or you may multiply, like what you do in your laboratories. It's up to you. And you just continue to do the same throughout. Okay. Then you write the mitigation plan in place. So you have your policy, you practice, you have your resources, and then you train people. On site, you train the people so that you prevent this. Remember, by modifying this, the severity is not going to go down. The only thing that can go down is your likelihood of occurrence. Your preparedness, when you become better, will go down. And when your likelihood of occurrence goes down with numbers, when your processes improve, it goes down, then your severity still will remain the same. Okay, so that's not going to change. So please, you don't have to change severity when it becomes better. So please remember that. Okay. Let's look at the environmental cleaning and surface disinfection. So this is something that we look at, risk stratification matrix. This is something that I picked up from the our CDC 2019 document for surface cleaning and environmental cleaning and surface disinfection in low and middle income countries. So it clearly gives a risk stratification matrix on which environment, how do we clean, depending on level of contamination, whether there is a heavy contamination, medium or moderate contamination, light contamination, what kind of patients are there? Is it an ICU or the ward or the OPDs or non-patient care areas? Or what type of surfaces do we have here? Do we have a frequently touched space like the doorknobs or the IV stands, the bed railings, the keys, the monitors, etc., or the low touch surfaces like the floor and the walls, etc. Then you add the score and then you apply the score. Depending on that, you will tell how often you want to clean them, with what you would want to clean, what solution do you choose, what concentration you choose, how often do you want to clean these areas, and who will clean these areas. You can even color code them. So this would depend, depending on the, your matrix that you have given. Okay. This is again another example of a CDC's risk assessment tool for calculating the workforce immunization. This is from the actual document itself. So what they've done is they've taken 4 categories. They've looked at workforce immunization, workforce assessment of immunization status, pre-employment on the commencement of work, and existing employee categories they've looked at. Then also looked at exposure, opportunities for exposure in people who are working in this environment, and what are the consequences of these vaccine preventable diseases, to see, whether they have been, whether it is available or not. So then you score them, then you rate and say, what is the risk? So accordingly, you can prioritize what vaccination should I spend my money on, who need to be vaccinated more. So even in the NCDC document, it clearly mentions on categories of people who need to be vaccinated even for hepatitis B. So you can use this matrix to identify or prioritize so that you can justify the amount of money spent on vaccination to the effect it can cause. Now I'm going to take you through another example, which is again has multiple processes. If you look at CSST per se, you can see the entire CSST in 3 different zones. You have the dirty, clean, and the sterile zones. And these have specific activities of cleaning, disinfection, sterilization, and storing of materials and supplies, which may be reused again in the facility. So you have, when you look at the risk, so this is the best way to do a risk assessment. You walk through the process. It's called as process mapping. Of course, you do this for IPC as well. IPC has very complex, so you look at multiple areas, but CSST, single flow, single activities, you can kind of, so you just close your eyes and say, okay, if you are a dirty instrument, what happens to you in the CSST? Or what happens to a CSS, for a dirty instrument that's walking into the, or brought into the CSST? So there is decontamination. Then there is, disinfection, drying. Then you inspect, assemble, pack, load, sterilize, check for the parameters, see whether it's functioning, okay, and then you store it and then issue. So this entire process, you can see what all can go wrong in each of these areas. So let's take an example of decontamination. If the instrument is not washed, it's left to dry for some time and then sent to the CSST, morning surgery at 6 o'clock, and the instrument reaches the CSST at 7 o'clock in the evening, and it's all stuck to the instrument, okay, dried blood and tissues. This, after you soak, also may not leave the instrument. So there is a risk of having these contaminated materials still sticking on. Okay, maybe one simple activity of not washing immediately or not covering it in a foam gel or in a wet towel before sending it to the to the CSST. So this may be just one activity. Not inspecting them can lead to having a chipped instrument, a rusted instrument, or a broken instrument in your assembly. Not packing it properly can. So you can have such multiple risk areas in the entire process of your CSST. I'm just taking 3 such areas just to help you understand how we prioritize. Okay. So let's see overloading of a sterilizer. Probability of its occurrence is very often occurring in this particular hospital. Okay, just to give you an example. Now, does it have an influence on the sterility? Yes, serious influence, because all your instruments are not going to be sterilized properly, and it is happening very often. And there are times it is happening more so in the night, and then also sometimes in the day when some people are working through the day. So the preparedness or detectability is poor still. So you have 3. So you add it, you get 11. Let me take you through the second one, which is packaging. Instruments are punctured through the packages. Okay, probability of occurrence is very less often in the CSST, but what does it have? The consequences are poor because it can lead to contamination of these instruments. And is it being detected? Yes, every time it is going through a process, it is checked and verified. So if you see, it is occurring very less often. It is clearly checked and verified and sent. So therefore, the risk score is 5. 1 plus 3 plus 1. Instrument sent to the CSST with dried debris. The example that I gave to you earlier. Probability of occurrence is 3. Okay, it's occurring more in the night surgeries compared to the day surgeries. Severity, depending on the type of instruments. Let's give an example of 2. Detectability, in the days it's getting clearly checked and verified, but it is in the night it is getting messed out. Let's give an example of 7. Now, if you see, one of them is in a high priority with more than 10, the other one is in, and then you have low, and then you have the medium. Now, what is important is when you prioritize, you have to list it as sterilizer. Overloading of sterilizer is my first priority area that I need to work. And the second thing is I will start working on instrument to be checked for dried debris, etc. The third is all that we look for, punctured through the packages as my third one. So that's how I prioritize and start to work on this as well. Yeah. So we could do the similar for preventing healthcare-associated infection and MDROs as well, multi-drug resistant organism, Klebsiella, VAP, SSI infections, and all kind of drug-resistant organisms, Clostridius difficile infections, or MRSAs, VREs, colistin-resistant organism, carbapenem-resistant organism. You can list them and you can prioritize depending on, so my hospital, I can have surgical site infection as a more concerning one compared to the COTI in your hospital. Okay, so your facility to another facility can have differences in terms of the type of organisms and the concern. So my concerning organism is different. My concerning healthcare associated infection is different as well, depending on the score that I would give based on what I see in my own settings. Okay. So when you start to prepare your risk assessment matrix, you try to gather all the risk under the categories of community related, geographical related, population related, prevalent related. So this may be non-specific. And then you have those specific areas where there is patient specific, pediatric patient. Okay, those transplant patients or those patients from the oncology wards or bone transplant unit patients or dialysis patient or ICU patient, surgical patients or healthcare workers related or procedure related. It could be, it could be dialysis as a procedure. It could be cesarean as a procedure. Okay, so any of these procedures or equipment or device related, specific to a particular equipment or environment related, or it could be specific to a treatment that's given. So I'm just giving you another example. This is from the Nebraska ICRA grid matrix that was shared. Okay, so I'm just taking it from the document itself to show you. Uh, I'm just taking a screenshot of that particular document just to share with you what all it looks at in a healthcare related. You see that? I put that list, the second one is healthcare worker related. This is from that. It's the healthcare worker related risks. So it lists everything that is related to the healthcare worker. And then you put the probability of occurrence, impact, preparedness, and you give a score as well. In all of that, you will see it's all, here there is a multiplication that's been done. Okay, it is 1 into 3 into 2, that's 6, etc. So in Nebraska's ICRA grid, it is multiplied, unlike the JCI that we have saw it being added. Okay, so you can choose any, but always maintain the same. So here, you will see these 3 components being there, and that's your final score. Then you look at what is the highest. So the healthcare worker immunization not up to date is my highest risk. Okay. Healthcare workers working while they're infected is my biggest risk. So my priority is, restricting work restriction, implementing work restriction when people are sick. Second is to ensure that everybody is getting vaccinated. So in my healthcare worker, hand hygiene is scoring 4, which is very low compared to my other concerns. Then would come all my 12s, if my 18s are those scores, and then all my 12s, which kind of looks at employee outbreaks of infections, infection prevention policies, procedures, staff knowledge being poor, then, not adhering to standard precautions at all times by the healthcare professionals, maybe the third. So these are the things that I work first with before I start to do the others. So this will give me an idea on what do I prioritize first. Okay. So let me take you to another next level. All right. So I list everything. Okay. So then I score, then I find my risk 1, risk 2, risk 3, and risk 4. It's again just an example. I'm just giving you arbitrary examples. Hand hygiene complaints being poor. Surgical site infection among specific groups of surgeries, which is, CABG procedure in the cardiothoracic unit. Compliance to vaccination being poor. And then my MRSA infection rates being higher. So these are my prioritized area from all the entire list of all that identified in my organization. So what do? I put those as my events. Then I will say my risk reduction goals. I will define my risk reduction goal based on my priority risk. Okay. For all those who've been from accredited healthcare facilities, if you see the 5th edition standards of NABH, or the 6th edition standards as well, it kind of focuses on risk reduction goal. Of course, even the 4th edition has it. So it will mention the risk reduction goal, which means in your infection prevention control program, you identify some of the risks as your goal risks for the year and start to work on them month on month, and you monitor month on month to see its performances. If it's a rate of infection, you want to see it going downstream on your graph. And if it's compliance, you want to go it upstream on your graph. Okay, so this is something. So when I say my goal, for example, 42% hand hygiene compliance is my risk, then I would say my goal is to ensure at least 80% hand hygiene compliance by the end of 1 year. So that's my goal. So for that, I will make a list of things of how I am going to achieve that. So my objectives are clearly written down on how I am going to achieve that. Okay, so then I will have strategies in place. I will put personals in for that. And I will also have some methods of evaluating whether it is happening or not happening, either by auditing or looking for outcomes to see for its impact, etc. So I will kind of look at it. So there is a risk identified. Now I have a risk reduction goal defined. I have an objective in my mind written down, which is measurable. Then I have strategies to work on them for implementing them. So when I start to put my strategies, I am going to do this by, teaching and training people, keeping materials available, prompters and posters there everywhere. Okay. And nudge, positive nudging of personals as the most important strategies that can, and reminding people whenever they have missed out. So these may be my strategies. So I put people, I could put my IPCNs, I can put my link nurses, I can put other people also to do this job. And I keep looking for the scores month on month to see whether it is improving or not. So this is my evaluation strategy. Now, how is this risk assessment in our infection prevention control program of the organization? So whenever you define for the organization, so if it's an eye hospital, I have my infection prevention control program specific to the eye infection, procedures, focused areas, etc. If it's a multi-specialty hospital, my program is going to be multispectoral and it's going to be wide, covering various aspects, which will include all aspects of my IPC activities. Okay, so and focus areas as well, right? So I will include the regulatory requirements that need to be adhered to, apart from my my risk assessment based prioritization, which may be from the CDC or WHO's the assessment tool kits or framework that I have. And I kind of look at my gaps and identify them, or do the scoring and then put them as special areas of focus. Then I will write down my risk reduction goal and I will write down my measurable objectives as well. So then I will write the policies, then I have timeline, I have people responsible, then I also have feedbacks. No risk assessment program is complete without taking feedback from people who capture it. If they say, oh, this is very difficult, I'm not able to score it, if I'm not able to do this, those things should be taken as a feedback so that you modify the methods of capturing, modify the methods of, identifying the risks that are there so that you can revise it. Sometimes you are not able to score it. If your team says, oh, I don't know how to score this, I don't know how I will define this, etc. So this will definitely give you an opportunity to revise your program. This is just an example of what the JCI would say, and it's one of its requirement in its chapters, okay, on PCI or IPC. It kind of looks at your risk assessment is one of the very, very important thing that they look for. So they look at the probability, impact or severity, whether it has any financial implication, legal, regulatory or accreditation requirements included. Also kind of looks at what is the existing system. So this is one of the checklists that they choose to have for your ICRA by the JCI. This is the 6th edition standards of NABH, which also tells about this, the IPC program itself, an organization's IPC program is based on infection control assessment tool. Remember, this is not a risk assessment tool, this is a gap assessment tool, and also looks at the risk of infection during construction and renovation. Okay, so these are specific things. It also looks at the IPC 1, also looks at the risk reduction goals that you identify. Okay. These are the WHO and CDC framework that I was mentioning. It kind of looks at 8 different areas of activities that it kind of looks. Okay, it's the CDC will look at 9 and this one looks at 8 different areas for framework, and it kind of scores them. And you see this is a scoring pattern that you will see, and depending on that, it'll say inadequate, basic, or intermediate, or very advanced level of adequacy that is there, more than 600. Then that means you're doing really well. So there are questionnaires. You have to just answer these questionnaires, and that's good enough for you to see. So it kind of so the CDC one helps you to look at everyday activities. Are people using PPEs well, etc. Those kind of things are well used, well assessed by using the CDC, response framework, response tool. And the WHO's framework one kind of looks at, strategic program development, looking at it holistically in all aspects, etc. So you can choose any one of them, or a combination of both can be used in the organization for general all areas as well as specific acute care areas. go to the third aspect, okay, of our risk assessment analysis. I'm going to take you through, imagine yourself, in a facility where you have 750 bedded tertiary care hospital, which has decided to renovate its oncology wing. So what did they plan? They had a meeting. They discussed on infrastructure upgrade. They looked at the budgets to be approved. The architects kind of finalized the project. Then the contractors were appointed to start working on the oncology wing. So I want all of you to tell me what all should have been done apart from this in a hospital. Ready? Can you all hear me? Very good. You're a very smart audience. Okay. Take opinion from the ICU and planning. Risk assessment before construction. Very good. What is the infection risk of OTs? Very good. Pre-assessment. Very good. Okay. And this is a very, very nice set of postgraduates and consultants, I guess. Excellent. So what all will you look for? Okay, what should be looked for? Okay, whether there is any negative pressure containment in this zone, HEPA filters, air particle monitoring, construction debris being transported through the patient corridors. Whenever you're drilling out on the ceiling, etc., there is a ventilation disruption, so you have a HVAC disruption happening. So these need to be planned as well. So you all are right. So we do what is called as pre-construction and renovation related infection control risk assessment, or ICRA, which is called as PICRA or PCRA. Now it has three components. Okay, so the components are very simple, just like what you see. Look at the severity and likelihood of occurrence and the preparedness that you have. Here we look at what is the activity, what is the type of construction activity are we talking. So it is A, B, C, D. A is very, very minimal, very non-invasive procedures kind of thing that we do, inspecting, removing a ceiling, just to touch up of something, etc. Right? The type B is a little bigger than that, where you're adding more, you're clearing some space, you're cutting out a wall, small, little bit more than the non-invasive one, slightly invasive one. Then you have the type C, where you have, where you are removing the floor coverages, ceiling tiles are removed, etc. New walls are being constructed, small ducts are being made. So small activities which are done, which is bigger than the previous. Okay, that's type C. Type D is big, breakage of walls, the construction work that you do. So you're breaking the wall to make it unidirectional. You're removing, you're making your old facility into a newer theater complex to accommodate new sets of facilities that you are planning for, etc. So this is major construction or demolition and construction work. So you have something like very, very minimal of inspection type to that of major destructive type. So you have A, B, C, D. Now this A, B, C, D, all the four can happen in four different areas. In a very low risk area like a office room or a accountant's office, etc., to a medium risk area to a OPD, to a high risk area like the ICUs, to a higher risk areas when you have your transplant units or cath lab units, operating theaters, oncology wards, etc. So you have the highest risks there. So you have the low risk to the highest risk here. Now, when you put a 2 by 2 table of your low risk group having a type A activity to that of a low risk group having a B, C, and D activity, similarly medium, the high risk group and the highest risk group, the A, B, C, and D activities, you have four different categories. You put them as 1, 2, 3, and 4. So you have these four for which you pre-prepare your control measures. So you write your control measures prior and you say, okay, this is what needs to be done during that time. So before construction activities, what should be done? During construction activities, what is done? And upon construction of activities, what need to be done is clearly written down. Okay. Okay. So this is something that needs to be done. Okay. So let me take you through that. Okay. This is something that you would do. So you will clearly describe and write it down, and you will, you will, for each one of these colored zones, 1, 2, 3, and 4 of, you will say, okay, for this, during the construction work, what needs to be done? After the construction is over, what needs to be done? So this is written down as mitigation plan in place, and you don't wait for, everything to be done and finished, right? This is just one example, like a project permit. This can be prepared in our own organization. You can make it the way you want. Okay, this is just an example. You can choose to make it the way you want. Location of the construction, who's person coordinating this, contractor who's performing the work, who's supervising this, when are they going to start this, how long is it going to do this work, and who's the contact person, their contact numbers, etc. What type of work or construction activity, depending on A, B, C, D, which area is happening, 1, 2, 3, 4. Okay, group 1, 2, 3, 4. Then you will put the class 1, 2, 3, and 4, and you will write down specific to the type of activities you will write. Okay, so you will give it to them and you will say, this is what is required, and you clearly explain to them and you sign and give it to them. And you could have a periodic check line where you will say, okay, these are the times that I will meet up with the team and see that it has been done the way it is been recommended. So you will have to, the IPC team can go and visit and check and verify whether it has been done in the way that has been described. So this is a permit, and once it ends and you have it filed, and that's the process, right? So we come almost to the end of it. So role of capacity building is very important. Who needs to be part of the risk assessment team? So first of all, you need to create awareness, encourage like-minded people to participate, form a team, train all of them concerned, develop modules and resources of how it has to be done. And when it is done, give it to people to review and say whether it is easy for them to understand, is it easy for them to perform. Give mock scenarios and get the teams to give scores so that you know which of them are found difficult by the team members in scoring, which are the ones. So you make it simpler so that they are able to capture it properly and they are able to score in a very standardized way. So the final and the take home is that whenever you plan for an infection control risk assessment, always identify what the problem is, evaluate the problem, how it would be. So then you follow the process, you walk through the process, and then you identify the risks that may be there. Then you look at the likelihood of occurrence as well as the severity and also the preparedness, of course. Look at the priority based on the scores, the high priority, medium, and the low priority one. So you can list all of them and score them all and see which one is your big problem. And then you focus on its control and mitigation action plans. Continue and monitor and evaluate whether they are improving better or not. So like I told you, you can have your risk reduction goals, which needs to be periodically monitored every month to see whether they are improving. So end of a year, you review again all your risks. Now you will find, for example, if your needle stick injury was your biggest risk and a problem, and you had some focused action plan for the year, and you've been doing continuously something, you're ensuring things are in place, you have modified the methodology or chose a different type of needle types also. When you have such things, then the needle stick injury is not going to be a problem, and that's not going to be a top priority for the next year. So your program, your IPC program for the next year will have a different priority list by itself. Your program plan changes. So yearly evaluation will bring about change as well. Then now you again look at what's your problem now. So something will definitely be a problem if you list it, because it's going to be there. The scores may be lesser, but definitely it's going to be a problem. Whatever is your problem, you start to address. The very beautiful thing about all of this is that when you start to identify your problems and you address your top 20% of your problems, your 80% gets automatically solved, because most of them requires a similar thing. It's training, having hand washing in place, ensuring that people are more knowledgeable, you have your information, education material placed appropriate places, and you have improved the type of activities and materials available as resources in the system. So all of this is going to modify the whole risk process that you would see with IPC itself. So always look at, first of all, we need to perceive that there is a risk or look for it, then you assess it, then you communicate with the team, and then you manage it. Always look at how to move to a proactive way of handling risks rather than being very reactive. Okay, so look at being proactively, even before it occurs, what am I going to do to address it? So you're well prepared and you are in control of the risk and not the risk control over you, because otherwise you will have outbreaks for you to handle and more horrible sequence in the system for you to handle as a IPC team. So thank you very much, all of you, dear friends, for your patient listening. And I'm now open to all questions that you may have. If you have any questions, please put up in the chat box. Or if there are any questions that I can see in the chat box, I can start to answer them as well. I think you can start asking even on the mic. It's okay. I think that'll be more interactive rather than just me reading out your questions. Okay. So it's a beautiful question, how to decide what score need to be given, like out of 1, 2, 3, 4. That's why I said you need to have a team and look at each problem. For example, needle stick injury in an area where your HIV prevalence is higher and your hepatitis B prevalence is higher, your severity score will be definitely higher than what I would score in my area. So it's something that you have to decide at your own end. Okay, so in your 1, 2, 3, 4, 5, okay, you can choose, but consistently keep it as same. So that's why you have to prepare your module or your document and say clearly, this is what I'm going to score when for these problems or for these issues, these are the ones that I'm going to be scoring. Okay. So what is the other question that you have? Thank you all. Thank you. Okay. Okay, I don't see any other question. Questions? Okay,
That
I
was
don't see.
very well described, ma'am. So I don't think people are ready to with questions yet.
Thank you so much.
It was very nicely done, ma'am. Thank you so
Thank you.
much. You took us
Thank you.
nicely through the journey of the infection control risk assessment.
Thank you. Thank you very much.
The audience was also good, actually.
Yeah, they're very good. They were very interactive. That score will vary from person to person. That's right, Mariam. You're right. That's why I said you need to have the team with brainstorming and score defined, written down in your module, so that everybody gets trained to so that you ask somebody to go. So you have to give some mock scenarios to people and say, okay, now you assess and tell me how will you score it. So once they have given it, you just assess and say, okay, why did you give 4? Why did you give 3? Then they will tell you. So you sort that out, modify your pattern or way you will assess the scenario. Okay, so that will help you standardize your numbers. So otherwise it's going to be the same. Everybody is going to give different numbers. Now this different number is going to alter because when I say 4 and you say 2, okay, and if you're going to multiply, that's going to become a big number, and that big number is going to be as high priority according to you. For me, it is going to be a medium priority, and that's not in my list for this year in my infection prevention control program. So my program is not going to address it if your scoring was lesser and my scoring was higher, or the vice versa. So always have a standardized methodology of scoring. So you should have some team member who will always review it. Okay, so periodically reviewing, meaning I would always look at once a year. Okay, initially what you can do is what is happening in a month. You will definitely have your IPC data. So what is happening in a month, you will see. And then you can take what has been available in the literature of needle stick injury, MRSAs. So IPC is something that has been spoken about so much. Everybody has a lot of experience. Each system is different. So you can be as creative as you would want to be and get more out of it also. So, but when you take, so if I'm taking a likelihood of occurrence, something happening every day is my biomedical waste disposal not done properly, PPE not used properly, hand washing not done properly. These are going to be an issue that I see every day. But what I would see once a week, once a month, once in 6 months, once a year or never would be my number one. Okay, what I see every day will be my number five. So periodicity, if I have to see for it never happened for a year, then I should have followed for at least a year, isn't it? So for me to score for that, I need at least an annual data. But for me to know what all I should look for, I should have at least a month's data or a quarterly data to see what is happening. Yeah. Okay, any daily checklist? Okay, that's a nice question actually. In the laboratory, we have something called as risk register. So every day, whatever your NC that you're capturing every day, you put that. That's a very good thing to do because in my institution, what we do is we capture that and we put them as in one Excel sheet. We keep putting what all we find every day. So we will know likelihood of occurrence. The severity, like I told you, will not change. Okay. System A, system B, severity will be the same unless it is like, infection specific to that area. Otherwise, it is going to be the same, right? So, but likelihood of occurrence is going to be very different. So if I have data for something every day captured, then I will be putting that. And end of 1 month, I will know how many of needle stick injury I had, how many times, what was the rate of infection, my VAP rates, CLAPSI, COTI, all of this would be easy. Okay. So OT swabs can be collected, for example, tetanus. OT swabs to be collected for error. Okay, this is out of syllabus questions, but still I will answer. OT swab collection is really not required. It's not a must for you to look for surveillance of theaters. Okay, surveillance of theaters, is done only when you are starting a new facility. You've converted a room to a theater, or a new theater has been there, or whenever you've changed some practices within that area. You've either changed the system, you did your HEPA filters and you want to check the flow, you want to see whether it is doing the job well, or when you've changed the disinfectant solution, or whenever there is an outbreak. See, these are the times when you want to swabs and you look for. Okay, so otherwise it's really not required to as a routine. Okay. But if you if you're in a process of doing it, should have a structured, standardized process of capturing air quality by either a settle plate or an air sampler. Swabs, if you do, it has to be very, very clearly done and focused. Otherwise, it makes no sense. Case of minor fire accident in OT due to air conditioner circuit and use of fire extinguisher in a lower source, as same as for construction or repair works. No, 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 no. So this, what people will do whenever there is a fire accident, that would be a so we are not looking at the risk of fire in the theater. We are looking at risk of infection for when people are coming to handle the fire in the theater. If people are rushing inside, so there is a theater, surgery is happening, and there is a fire, okay, and people run inside to save people. So what is the risk of infection risks the people would have for barging into the theater is what we will be looking at in IPC. We are not looking at the fire risks. We are looking at infection risk in any kind of these situation. How to convince OT people not to do the swab test. It is not mandated. It is not recommended by any system. Okay, there are some government document which mandates you, of course, I can't say not mandated, mandates you to show some swab test being done as a routine. So still that is removed from the government systems. We will not be able to completely stop, but it will see if you look at swabs, what are you going to do out of those swab reports? You are cleaning the site and then taking a swab. and you're not looking at the quality of the swab during a procedure, during something happened, etc. You're looking at whether the cleaning was done well or not. Sometimes your mop is so dirty that the swab before would be no growth, after mopping would be with growth. And whatever organism grows in your settle plate, you're not even screening and looking at all of them also. So you're not looking at all organism. You're not looking at what is. So it's a very undirected activity. So it is making no sense. So it's better don't do it. So if your clinicians say, oh, you have to show us the swabs, etc. So you can show guidelines saying that it is not recommended anywhere. Okay. And if they still insist on doing, and if it is government mandated process, so there are the government document itself tells you where all to take. Okay. Do that, document it. Okay. But when you do it, and see to that you are doing it in a structured way where you are able to see at least the cleaning is happening or the airflow is happening well. Your flow is happening well. Something you should learn out of it. Otherwise, it's a total waste of resources. Right?
Thank you so much, ma'am. I think we'll call it a day.
All right.